Well, hello, everybody, and thank you again for joining us on the Akal and Kuka Report. This is our maybe fourth or fifth episode on brain death. Uh, you know, Habitual listeners will know that this is a topic that is very dear to my heart. And we have the pleasure to have again as our guest Dr. Dwayan Nguyen. Dr. Nguyen was previously an academic hematopathologist and is currently a Catholic moral theologian and bioethicist. She has authored books and articles both in medicine and in moral theology and bioethics. But in particular, she's authored a 600-page book, monograph, that takes a critical look at brain death from a variety of perspectives. And it's an awesome reference. I don't think there's anything like it in the medical literature. Dwayan, welcome to the show.
Thank you.
So, Dwayan, you and I have thought about this question of brain death for several years. Let me ask you, actually, before we get into it, what got you interested in brain death?
Well, I was in Rome, in Angelicum, and I was studying moral theology, and I was getting into the license. When you get into the license level, that's when you have to start specializing whether you are going to study Bible, biblical theology or moral theology. And I walk into moral theology, and then the first person who came in, my professor, it was a course on death. All right. Before that, I took several other courses on death, but regarding biblical theology. And it was like I said, "Oh, this person is going to be my moderator for my license thesis." Just like that, all right. Then I found out that he actually had done work on brain death as doctoral work, although he's not a medical doctor. The person who supervised him is a medical doctor who have done a lot of work on primarily vegetative patient, especially pediatrics, and he has done several kind of innovative therapy, and there are some people who would qualify as brain death, but because of the very prompt treatment, all right, so they recover fully. Anyway, it got me interested in brain death right then and there. But because I have a medical background, and so I progressed far much further than him, and also in terms of moral, in terms of philosophy, I know far much more than him, and so I was able to progress. He never got his doctorate. He was my professor at the license level.
So he was, if I understand you correctly, he was a brain death skeptic, if we can call
No, he's not a skeptic. He's not a brain death skeptic. He was actually, he was against brain death. The very first person, the first class he showed was a video on Zach Dunlap. It was very impressive because Zach Dunlap was declared brain death. It was supposed to go for organ donation, and his cousin came and pulled out the Swiss knife, okay, and did a real strong, stroke right on the plantar, and Zach Dunlap would draw his leg like that, and the whole thing get cut off. All right. After that, Zach Dunlap woke up and went through therapy. And right now, this story has been like, I don't know, 15, 20 years. Paul Byrne actually went to see Zach Dunlap in 2019. The man is alive and well, married with children. Okay, now he's a Protestant and his family consider it to be a miracle. Well, for me, all right, before we jump into miracle, we have to look for natural reason. And if there's anything that can call miracle is the fact that his cousin came within minutes before the patient got wheeled into the OR in order to have organ yanked out. All right. So that case was very, very well known, actually.
Okay. So your professor was against brain death, but he hadn't really developed the philosophical arguments,
right? No,
as of yet. And then you decided to sort of look into it.
Yeah. I had no idea that I was getting into what they call Yeah, another Dominican. All of these people that I was dealing with were Dominican, and so Nicanor Austriaco, he said to me, "What, you are going to do work on brain death? Do you know how great a controversy that is?" And they say, "But this whole thing is so simple. These people are not dead." Well,
Hmm.
obviously, then I embark and I have to prove not just from the certain. I prove that from the viewpoint of medicine, empirical data, and if you from the viewpoint of Aristotelian Thomistic metaphysics as well, because if your philosophy is a good philosophy, then it would be confirmed by the data and vice versa. Okay, we call it realism. And then also, I did something that nobody have ever done before. It's called the contemporary holistic biophilosophy.
Okay.
Yeah, which also proved that brain death is not death.
Okay.
Okay, that is actually in the chapter 4 of my book. Okay.
All
And
right.
some of the argument of Schumann is actually taken from contemporary biophilosophy, although he did not develop them completely fully. Okay.
Okay.
Yeah.
So and Alan Schumann was a guest on, again. I don't want to lose the audience
Right.
here but Alan Schumann was a guest on two of the prior episodes we've had. Okay. So what I thought I would do here, since Anish will represent the voice of the of the people, and Anish is a physician, and as most physicians are, they either have not given the question of brain death much thought, or they accept it because it's essentially the dogma of the day, and no one in medical schools questions it, um, with really minute exceptions. So I'm going to start by reading an excerpt from the paper. We've talked about that paper before. It's the paper that was um, published by a team of ethicists and physicians at Harvard in 1968. And it's a landmark paper because it's the paper that essentially proposed the concept of brain death to the world. The title of the paper, interestingly, doesn't have the word brain death in it. It has the title is A Definition of Irreversible Coma. So already we have a hint here, because in those days, they describe the patients, which we now call brain death, as patients being in an irreversible coma. And being in a coma, by definition, you would need to be alive as opposed to being dead, right? We don't refer to people who are dead as being in a coma. So that's the title of the paper, 1968. It was published in JAMA, and I'm going to read the first paragraph, and then get maybe Anisha's reaction. So here's how it starts. It says, "Our primary purpose is to define irreversible coma as a new criterion for death. There are two reasons why there is a need for a definition. One, improvements in resuscitative and supportive measures have led to increased efforts to save those who are desperately injured. Sometimes these efforts have only partial success, so that the result is an individual whose heart continues to beat, but whose brain is irreversibly damaged. The burden is great on patients who suffer permanent loss of intellect, and on their families, on the hospitals, and on those in need of hospital beds already occupied by those comatose patients. Number two, obsolete criteria for the definition of death can lead to controversy in obtaining organs for transplantation." So those are the two reasons why they decided in 1968 that there was a need for a new definition of death, or at least new criteria to define death, or new criteria to state that death has occurred. One is because of the intensive care that was now available that created this condition of irreversible coma, and they thought that it was um, an undue burden to the patients themselves, to their families, to hospitals, with beds being occupied by people who would remain in such a condition. And number two, they say that, interestingly, they say obsolete criteria for the definition of death can lead to controversy in obtaining organs for transplantation. Well, all of a sudden they're obsolete. I mean, they haven't made the case that that the traditional criteria, the cessation of pulse and respiration, are obsolete. They just declare them to be obsolete. Any thoughts about that, Anish?
Yeah, no, I mean, I think that's poorly done. I don't think you should change. I don't think you should, modify definitions for brain death or irreversible coma because, now you can transplant organs. So yeah, I mean, that's a problem.
Right. Yeah, I think I would say that's a problem. I don't think people are aware of that. But it was. I mean, to me, it sounds like. I mean, it seems. I wouldn't say naive, but it seems at least forthright. I mean, they were not trying to hide
I,
it. At least they were sort of
well,
pretty frank about it.
I think it's poorly worded, or I mean, at least in my opinion, it's poorly worded. I think there is somewhat of a pragmatic need to deal with the dying or the near dying, or and so there's of course plenty of people that are in the process of dying because they need an organ. And so you just have this pragmatic mismatch, happening. So I mean, I understand the intent of it. I don't know that I would ever put the need for organ transplantation into a definition for brain death, but I mean, I understand where they're coming from. You would like to have some type of guidelines, not necessarily something that everyone has to live and die by, but some type of guidelines to help physicians who are dealing with folks who are near death or are, who may have an irreversible coma. If that, so I think it's reasonable. It's like we have guidelines to decide when someone should get their appendix taken out. That doesn't mean that every single person who comes in with right lower quadrant abdominal pain who has inflammation around their appendix necessarily should or has to get their appendix out, but we still have guidelines for that. So
Right.
I mean, nothing wrong with a guideline.
No, I understand, but here I think the problem that they were facing. I mean, there's a need in this situation, which is not the same in the situation of having to take an appendix. There's a need of. I mean, being, they need to declare that somebody is dead before the organs are taken, because the alternative is a big problem. Do you want to speak to that, Dwayan, about why is there a need to?
Well,
to
I tell you
declare,
something. That behind this paragraph, which sounds as if it was straightforward, and you had to allow me to speak a little bit long, is a whole contorted story. All right. There are external circumstances which precipitate the Harvard to work on this, and they work behind doors. Okay. Well, anyway, to make a very long story short regarding the external circumstances, and then I would provide the internal evidence. The external evidence, well, first of all, let's begin with what the definition of death before 1968. All right. Before the 1968, when you look at encyclopedia, definition of death is cessations of all vital functions of the human body. It does not give priority to any single organ or organ system. All right. Now, all vital functions, but obviously, the key manifestation would be the heart stop and the breathing stop irreversibly. Okay. So, and then what happened was we have this Mollaret and Goulon, all right, who had le coma dépassé, which then get translated into English as irreversible coma.
So those were French. That was a French paper in the early 1960s.
Okay,
right.
In the 1950s. And Mollaret specifically said that before these patients, he would never put the polish chair down. That means he would never declare these people dead. Okay, never declare these people dead. And so then we have the London, the SIBA Foundation. When was this? I don't have all of my date here, all right? But we have the CIBA Foundation Symposium on Ethic in Medical Progress, all right? And it's with special reference to transplantation, sponsored by the CIBA Foundation in London. And one of the person who attended is John Murray, who actually became later a member of the 13 people in the Harvard the Harvard Committee. Okay, the Harvard Committee has its chair is Beecher. That committee of 13 people consists primarily of neurologist, neurosurgeon, transplantation surgeon, anesthesiologist. There's not a single cardio person on that committee. Okay, and there's one Presbyterian minister. All right. Anyway, so let me get back to this at the 1966 International Symposium on Ethic Medical Progress. There's this guy, Alexander, Belgian surgeon. He advanced 5 neurological criteria for death. In 1963, he already yanked organ from patients with head injuries. There was strong opposition against Alexander's approach, okay? And many people said that if a patient has a heartbeat, he cannot be regarded as a cadaver. John Murray was one of the person who actually say, oh, this is great, all right? This is great for our progress in transplantation. John Murray is a transplant surgeon. So and at that time, the term brain death was not started yet. The patient is called heart-lung preparation, okay? That's a term that is called about these people, all right? Anyway, so the conference ended without any decision. Okay. Oh yeah, and then these comatose patients are also called living cadavers. All right. Then the next thing that we have is obviously the Barnard sensational heart transplantation. Right. Notice the date, December 3rd, 1967. Right. And he got this, and the recipient died within 2 weeks, but it was considered such an advance in medicine. And listen to this, January 4th, 1968, 1 month later, the Dean of Harvard Medical School, Robert Ebert, he approved the formation of an ad hoc committee in response to an earlier request from Henry Beecher. And according to the Dean's letter, the purpose of the Harvard Committee is to study the ethical problems created by the hopelessly unconscious man and the necessity of giving further consideration of brain death. This is even before the paper got published, okay? Since many of the ethical problems of transplantation and other developing areas of medicine hinge on appropriate definitions. I'm quoting here, and all of the quotes I'm quoting here, that is from the correspondence between Beecher, the Dean, or the correspondence between Beecher and John Murray. Right. They are in archives at in Harvard, and they're available only to some historians, okay? And one of them published a paper, and I pick up some of these quotes. So, but what happened is when you study the internal evidence, the driving force which bring about this brain death by Harvard is organ donation.
No, correct, Dwayan. I mean, I think that's clear, and I think Anish is sensitive to that. But the point, I mean, that I'd like to answer here is I mean, what's the ethical issue? I mean, is there an ethical issue with declaring people who are, sort of in an irreversible coma? I mean, how do you? Why is it necessary to call them dead? I mean, why do we have something that is called the dead donor rule? I mean, there's right now it's I don't know if it's what kind of legal statute it has, but there's something called the dead donor rule, meaning an organ may not be taken from somebody unless they are dead, right?
Well, I mean, you cannot take organ from a person who is dead. Now, so the idea of the brain death, okay, there's a two situation. Is a person the comatose, severely comatose person, are you looking at a person with the potential, with the idea for organ transplantation, or you are just looking at this person and say, well, this case is hopeless and you should pull the tube, should remove the support, right? My professors in philosophy, we just pulled the tube from him. Just, he died in France just yesterday. All right. Now, back in those days, and I remember very well when I was practicing medicine, there was absolutely no problem. When you see the patient who is deeply comatose, going downhill, all you have to do is sit down and talk with the family and say, look, this is completely not working. All right. Hans Jonas also wrote about this. Pope Pius XII also said that there is no moral obligation to continue to support some case that is what we call hopeless, right? So you can remove the life support and you allow the patient to die naturally. Meaning, but there's no such a thing as do an apnea test, stick the ventilator back onto the patient, keep the patient alive in order to yank the organ. All right, that is the problem. So the problem is not the removal life support. All right. And for that matter, like Hans Jonas said, there's no need to redefine death. All you have to do is define, meaning establish a certain guideline. Yes, at which point can we remove the patients from life support and let the person cross this very, very unclear border between life and death.
Right. But I mean, I think the crux here is that the harvesting of the organs will bring about death.
Right, exactly.
Brings about death. So Anish, is that? I mean, do you see this a little bit differently now, or do you? I mean, do you understand what the issue is and what it was why it was necessary
yeah, of
for?
course, I understand the issue, but it's still it's still the pragmatic issue is that you have a large number of people that suffer significant.
Let's say they're right. They're irreversibly ill. Correct.
Yeah.
Right.
So I mean, part of the difficulty is this being it didn't really matter before. It didn't really matter before you had organ transplants, but now you have these folks with near death, irreversible brain injury or whatnot, and so you almost have to come up. Because of that, you have to come up with some type of arbitrary criteria that society agrees with to say, okay, if this has happened, then we as a society are okay with defining this person as neurologically brain dead, so that we can then do some good given the tragic circumstances that have.
Right, but I mean, if you're not going to do it
so I don't find it it's not particularly. I don't find it particularly.
Repulsive or
insightful or particularly meaning what is so yeah, you can be picayune because you've drawn a line and that line is by definition always going to be arbitrary, but as many people have said in the past, we drew a line because you had to draw a line. So the question is,
no, but I mean, why do you have to draw a line? I mean, do you think that because so the benefit of, I mean, essentially you would say that the benefit of organ transplantation is such that it allows us, I mean, that it's okay to call something dead that is not dead, or I mean, what's the
right? Because it would be tragic. It would be tragic if because you have an ability to take perfectly functioning organs and give somebody else a new lease on life.
Right. But let's say there's but I mean, could there be any other choice? So that's what I'm saying. I mean, if you're going to be consequentialist that way, if you're going to say, well, the ends justify the mean, essentially, because the ends is making organs available and the means is redefining, death, then you would say there'd be no other option. I mean, what would be the other option? I mean, is there another option, you think, except to redefine death?
Well, is it redefining death, or is it before it didn't matter so much, and so
No, it's not.
just
I mean, correct. It's
why
not.
not look at it as drawing a line? I mean, as being forced to draw a line which society kind of agrees with, not necessarily that. Yeah.
Right, but I mean, when you say society agrees with,
Mm.
I don't agree with it. So, I mean, that's essentially
Well,
the
yeah.
Right.
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 So the
Right.
question is,
And so when if God forbid something were to, I mean, those would be wishes that were clarified and elucidated. So that's why this conversation is important, that people have it and people listen to it. But individuals will make a decision.
right?
Will make
No,
their own
but I
decision.
mean,
So,
but I mean, they could have said. I mean, why didn't they say that? Why? I mean, what I'm saying is that what you say sounds reasonable, but that's not actually what they
yeah.
said. What they did. They felt the need to um, to come up with what on the face of it seems to be a contradiction in terms, right? I mean,
Right.
you cannot
Right.
be both dead and not dead.
Right.
You're either dead or you're not dead, so you cannot be both. And they made the choice, and we'll see a little bit how they will,
Right.
how it gets argued eventually. But they
Right.
felt very strongly the need to declare people that were manifestly not dead, declare them dead.
Right. Yeah. I mean, but you have to, again, it's not. I mean, you can't ignore the context, right? Even Pope John Paul II, right, in his 1991 address to the Society for Organ Sharing, he praised organ
Right.
transplantation as a new way for a man to make a sincere gift of himself in service to life through
Yeah.
the
Well,
donation of his
okay.
organs.
Right.
So it's not. I mean,
Yeah.
there's even an understanding within the Catholic faith of
Right, but I mean,
Right.
correct, and we'll
right,
get to that because I think it's
right,
very important to realize that it's not a religious question.
It's
That
not a religious
because
question.
it's been widely accepted by many religious people, including many Catholics. And nowadays, the majority of the Catholic moral
No,
authorities, if you will, are okay with the concept of brain death. So it's not. But the question is, again, I mean, don't you think it's a momentous thing to start calling living organisms dead? I mean, don't you? Do you think that would be, that?
oh, but everyone has different definitions for what living is. I mean, I think you have a
Well,
very different definition
no,
for living than I
no,
do,
no,
as we've
no, no.
talked
I
over the
mean,
years.
no,
okay.
no,
So,
no.
So let's make a clarification here.
Life is something that you have. Life is a reality, biological reality. Reality is something for us to discover. I mean, it's reality is not something that
So,
dependent on the on the
so
mind, on our
right.
mind. We have to
So
discover.
so let's actually make a clarification here because I think it's quite important to. You're correct. We're not talking about the definition of death. We're talking about the criteria by which somebody is called dead or not dead, which is a little bit
yeah,
different because I
yeah,
think it's actually quite clear and nobody disputes that if you look at a rock, it's not a living thing, right? And if you look at a cat that's playing around, that's a living thing. So the reason we need criteria to declare death are actually really social reasons. They're social reasons, and it doesn't really, because again, a body that has been dead, for several days, there's no controversy at that point, right? I mean, you don't need a medical doctor. There's no even professional competency to declare
right,
a true corpse dead. Anybody can do it. So the reason that the medical profession has been involved in the declaration of death and in coming up with criteria for death is for social reasons, is because in the moments that surround death,
yeah,
there's an ambiguity about
right, so,
whether a person is really, a body is really dead or not. Even when somebody, has a cardiac arrest, right? I mean, they have no pulse,
right,
they're not breathing. So there's ambiguity. And, I mean, 200 years ago, it was necessary to involve, it became kind of necessary for maybe public health reasons or for other reasons to have medical professionals be involved in declaring. I don't know exactly when the doctors became involved. I mean, I think that's something fairly recent
right,
involved, but at some point it became sort of customary for doctors. I think perhaps precisely because people started dying in hospitals as opposed to dying at home or elsewhere. They started dying in hospitals, and therefore it became customary for doctors to be involved with this process of quote unquote declaration of death, so that then after that declaration is made, proper steps are taken for burial, to inform the family, for that sort of thing. So um, there's an area of ambiguity, and the professionalism of doctors has been involved to deal with that, and I think there's nothing wrong with that. And
Well,
for the most part,
hold on. So and then maybe you can. Well, let me ask a question.
Yeah.
To both of you. If if somebody, you were talking, Dr. Dwayan, about somebody who's dying, and you talk to the family, and you pull the ventilator tube, and they subsequently die, correct? And in the case of brain injury, as we know, if you have a severe enough brain injury, you're no longer able to ventilate without the support of a ventilator, correct? So, I mean, is it why is this so? Meaning, if the person was going to be dead, if not for the ventilator that you have them on,
yeah, that's right.
Why is that not a? I mean, basically, what you're doing then is you're sustaining some type of function, and without you artificially doing something, the person would have died and would by all
right.
All right, Anish, can I ask you a question?
Corpse.
Yeah.
I asked Anish a question.
Sure.
Take the ventilator off Christopher Reeve. Then what happened to him? Just take the ventilator off Christopher Reeve, and what would happen to him?
No, yeah, right. But he has some. I mean, there's some function that he has beyond.
But what I'm trying to say is the dependence on the ventilator does not exclude, and you happen is in this person that is quote unquote brain death, as Michelle would tell you, he has a whole host of functions which are actually, how you say, working together. We call integrative functions. Okay.
Right.
So I mean.
Right. But I think the distinction.
But why is so why? I mean, why? I mean.
So I think, but I think.
Yeah.
I mean, I think you're right. I mean, an alternative would be to tell families, listen, your brother, your son, your whoever it is not dead. But if we get organs, he or she will die as the result of the organ harvesting. Right. And I'm not sure whether, I mean, I think I granted that at that point, the reaction, what would that do to the supply of organs is a bit uncertain, but I can only assume that it would be less than what the current supply of organs is. Because there is something about bringing about death in the process of
right.
Right. I mean, in a sense, I mean, you have to think, not only are you making the decision, you're making the decision for somebody who's currently alive, and so I think it's how should I put it? I assume that the people who proposed brain death were concerned that would seriously limit the supply of organs, and I think it probably would. I mean, I think it in fact, we have examples of that, right?
I think you're presupposing that. That almost sounds malicious. I mean, Dr. Dwayan, you asked me about Christopher Reeves, but nowhere in the modern world would we have Christopher Reeves who was able to talk and was able to do mentally was with it. You would never approach that family. I mean, because Christopher Reeves himself has his own opinion on the matter, but you would never approach the family and say, "Oh, let's take the tube out because things are not going well and he's going to die." I mean, so why it's obviously one point in a larger context, but the idea is that this blurring of between life and death, it's easy, the extremes are easy, but as you get closer to the closer to crossing over, it's much harder. Michelle is for some reason deciding to define death as when all the organ systems aren't functioning, meaning when you harvest the organs, you're inducing death. But that's not.
Okay, how about we just compare? Let's compare, okay? Let's compare the brain dead person. Let's compare the brain dead person with a person who is alive, okay? Put them side by side, and a dead corpse. All right, so warm and pink, does the brain dead person has it? Yes. Making pee-pee, does the brain dead person can do it? Yes. How about carrying a fetus to a gestation? Can the brain dead person do it? Yes. How about especially if you have brain dead children who get supported and who grow grow and develop into puberty, and for female they would have menarche. Yes, brain dead person has that as well. And so on and so forth. And they have temperature and so on and so forth. So these are the sign of the living. All right. These are the sign of the living. How about the feature, the only feature that the brain dead person share with the dead corpse is lack of consciousness. And the other thing what happen is whenever we test the brain dead person, let's not even talk about testing a brain dead person. When we test a comatose person, we look for a motor response. And if you are a neurologist, a neurosurgeon, you know that the neuronal arc, you have the sensitive aspect, and then you have an interneuron, and then you have the motor neuron. Well, we cannot assess the sensory neuron, okay? We cannot even assess the interneuron. We can only assess the motor aspect of the neuronal arc, okay? So what happens is the person can feel, but they cannot respond. What I'm trying to say is the testing cannot, cannot
at least
respond.
In theory, at least, right?
In theory. The other thing is comatose. What is comatose? Is loss of consciousness. Consciousness, we have level of consciousness. This is what we tend to think about. But there's also what we call content of consciousness. And this is a case of Zach Dunlap. He said, when I was, quote unquote, you guys thought that I was brain dead and was unconscious. I heard you guys were telling me that I'm dead, that you're going to take the organs out of me. And I was screaming inside myself, no, I'm not dead. Okay, he was telling, and he exactly said word for word what the people around him was telling when he woke up. Okay, so what I'm trying to say is the content of consciousness is private, is inaccessible. Okay, we are only, and there's no parallel between the level of consciousness and the content. They're absolutely unrelated, and there's no parallel.
Right. So Anish, I'm not saying, I think those are very good points, Dwayan, but Anish, I'm not, you're saying that there's a gray area between life and death. There's none. There's life, what pertains to life, and there's what pertains to death. The difficulty is in the criteria that we use to determine. So the definition of death as all organs functioning, that's not my definition. In fact, it's the definition that the people who support the concept of brain death came to.
But listen, my definition of life and death is very different from both of your definitions of life and death. No.
Well, what is your definition of life and death?
Meaning to me, if I suffer again, it's a very personal thing, but for me, if I suffer a large brain infarct or large brain hemorrhage that robs me of my ability to function in what I consider a meaningful way, then as far as I'm concerned, I've died, and I think people should. I think if and my family around knows that then please if I'm an organ donor and can be of use, go ahead and donate. So,
but that's a metaphor.
So why would I don't want you and Dr. Nguyen to make the decision for me to have me in some facility, with me being kept alive, because I don't want that.
no, but
I don't want. I don't
can I say something?
kept alive in the way that you. No, so it almost feels like it's authoritarian to kind of push a
no,
certain
but let's
thing
separate
of living.
the two. I mean, Anish, what you're saying,
Yeah.
I may as well be dead if you're irreversibly comatose. You're not you. So let's even take out all
No,
the
but
human. Let's
yeah,
take out all the human wishes and whatnot. Look at a cat that's made brain dead.
yeah.
If the cat is comatose, the question is it alive or is it dead?
It's
So
meaningless
it's
after
not. I mean,
that.
these are very
Yeah,
clear cut distinctions.
yeah,
There, it's not. I
right.
don't care about the wishes of the cat.
Yeah.
The question is it alive or dead? And why is it that we need to essentially obfuscate
Well,
the
yeah.
reality of
But,
things
I
and
mean, I think
obfuscate?
we would satisfy both of you by making up a new term, which basically says alive but okay, but willing to donate organs.
Right, but then
Right?
who's
Technically alive but willing to donate organs. So
right,
then if we had that new category, then I think that would satisfy both of you. You know?
that
The situation right now that we have in the real world is that this transparency is not being
Right.
made known to the public at large. All right.
Yeah.
And what happened is the public at large is under the understanding that brain death is death simpliciter. Is death, as a dead cat or the dead dog or something like that. Okay. And Coover and Gert said that death is a biological phenomenon. Coover and Gert was actually co-author with Bernard. All right. But they did say death is a universal phenomenon. Therefore, when we talk about the death of a human, it's the same thing as the death of a dog or a cat. All right.
right.
So that was, I'm quoting, I can't remember where he's written it. Okay. I don't have the text in front of me.
Well,
But
I
then,
have it
later
actually. I have the
on,
paper. That's an
right.
influential paper by
Right,
Bernard
but then
because
later on, they change them. They create a category for human, okay, because of the pressure of the organ and so on and so forth. All right. All so the on one my trying to say is on one corner of the mouth to say that death of the human is like death of a cat or the dog, and the other corner of the mouth say brain death is death, where it does not work. Okay, that is violating the principle of non-contradiction.
right. So I mean, Anish, I think you're correct in a sense that it would be an improvement if we were truthful. But I think my concern, even if we let us out, setting aside the ethics and whether there can be a solution for organ transplantation outside of the concept of brain death, the point is that I mean it seems such a momentous scientific. I mean, if you call it an error, or I mean, it's not just an error. It's an error on. I mean, it's a lie on top of an error. But
It's deliberate.
it is such a momentous thing to all of a sudden try to justify what is manifestly the opposite of reality. It's manifestly the
No,
opposite of
I don't
reality.
think so. I think the reality is that the reality is that there's a fair number of people that have tragic circumstances that befall upon them, and that both the individuals and their family members, are at peace with the fact that their loved one is
No.
is no longer
Anish,
there.
Anish,
So
let's go back to the cat. I mean, don't you say? I mean, isn't it an absolute scientific distinction between, and that's not. I mean, the scientists say that as well. I mean, themselves.
mhm,
There's an absolute. I mean, if you're going to be a scientist, if you're going to try to make sense of the world, you
yeah.
have to start by agreeing as to what is really, you know, what are distinct realities and what are not. I mean, because otherwise it'd be your opinion versus my opinion when we study the world. And the question of what is living and what is not living is not a
No,
matter
what I'm
of
giving,
opinion or preference.
I know, I'm giving you that. I'm giving you that. You may consider, someone who is on a ventilator. Someone who has a significant brain injury. You can
Mhm.
consider them alive by some strict definition, but in any, there's a large group of society, and I don't find them irrational, and I think we underestimate them if we think that the only reason they've let go of this person is because some doctor is saying they are brain dead. I think a large number of folks are okay with the idea that we need to we need to arrive at a way to let go and move on.
I mean, I don't dispute that, but although we don't know for sure, we don't know. I mean, at the end of the day, we haven't done that experiment, and therefore, why don't we do it?
Why would
don't
most
we
of
do
the
it?
medical
Why
community?
don't we agree that they're not dead? Why don't we agree that they're not dead?
I mean, that's why we're having this conversation. But right. Why would most of the medical community set up this framework? You think most of the medical community is you think most of our colleagues are such that they want to harvest organs from people that are alive?
But I mean, first of all, they need the consent of the family. They would need the consent of the family, which now in a way, we don't know yet. We really don't know. It's the families at the end of the day that have to make a decision. So long as the person is still alive, right? If the person is still alive, you're going to have to take into account the wishes of the family and their consent. Whereas if they're not, then it becomes, completely superfluous.
Right.
So I mean, I think that there certainly is a risk, and I think a very large risk to the organ transplantation industry. Again, most physicians and I, up until 6 or 7 years ago, it never crossed my mind to even think about those questions. Right. It really never crossed my mind. So I think. And I thought, I did it. I was involved in not in harvesting of organs, but in the process of declaring a patient brain dead. I was involved in that. I was involved in doing cardiac catheterization to make sure the heart was suitable for harvesting, that sort of thing.
Yeah.
So
I think it requires a lot of judgment, and it requires individual physicians' judgment, and maybe perhaps one of the things to come away from this is that
judgment for what? I mean, I'm not talking
the judgment to say that this person, that it is reasonable and not unethical to
I was hoping the conversation I was hoping the conversation would not be about the ethical issues. I'm hoping the conversation can remain on the scientific issue.
Right.
The question is, does it require any judgment? Does it require a lot of judgment to agree that the patient is alive?
But it's picayune. It ignores context and it ignores the pragmatic realities of what's happening. Dr. Dwayan brings up the case of Zach, the young man who Zach Dunlap. But for every one of those cases, we have no idea how many people are sitting in a nursing home right now who have no motor function, who are trached and ventilated, and are screaming inside that this is their life.
No. Okay.
I mean, how do we know? We don't know.
Okay. Let's separate the certain situations. Okay. Let's make very clear. First of all, we have patients who are, let's not use the word brain dead. Just call them the coma dépassé, irreversible coma. All right. All right. The question is, what you just raised there is, are they supposed to be kept forever and ever? Right? That's one issue. The other issue is, are they going to be organ donors? Right? So we have to deal. Are they going to be kept forever and ever? Well, I would say, practically, no physician has the moral obligation. It's not a moral obligation to sustain a patient that is either completely comatose forever and ever, because that is, you just sustain a piece of protoplasm. But the reality of is, hold on. Allow me to finish. Please allow me to finish. Please do not interrupt me, because I'm sorry, because you disrupt my thought, and then I because what happened is, in reality, if you know anything about biology, all right, the body, the clinical course of this patient depend on the kind of injury that we're talking about. Okay, if it's a young person, okay? And only the brain is injured and nothing else. And if you jump on the person very quickly with pulling all of the stops, then there is a good chance of recovery. It all depends on the primary injury. But what we have to do is to prevent the development of the second injury. The problem that we have is a young person that's falling into coma is an ideal candidate for organ transplant. All right. But we have to separate two groups of patients. The patient that you're talking about that, we are going to support them forever and ever, that has never raised a question, because the issue here is we can talk to the family and you can actually pull the tube out, or, remove them for life support. And that possibility was available even before 1968 and did not cause any legal problem, because believe it or not, I was among them. I was among the people, I was among the doctor who actually sat down and talked to the patient and pulled pulled from the ventilator. It is not an issue of changing the criteria of death. It's an issue of figuring out, and this is what the art of medicine, when we have to pull the tube and allow the person to just cross this ill-defined line between, allow them to die naturally as a language. The other thing is to send the person to organ donation. That is a completely different issue. And, okay, somebody who had a cardiovascular, a cerebral vascular accident, somebody that is 60, 70 years old, you don't even think about getting the organ from those patients. They're not good. They're worthless. But somebody who come into the OR about 20, 30, oh yes, you would want to get the organ from that person. All right. So, in that situation, it's not right. All right. One cannot commit evil to achieve good.
These are all opinions you're stating. None of these are factual things you're stating. You've made multiple different statements that are simply not factual. Meaning, so that there's 55-year-old people that have large strokes whose kidneys are harvested.
Yes, of course.
And then you said a 24-year-old or 25-year-old person, they have a chance they can recover as long as depends on. I didn't follow that. Meaning, a 25-year-old can have a devastating brain injury, and if you get on top of them and prevent the secondary harms that happen, they can recover. Is that what you said?
There is a possibility of them to recover, because you have to understand what is the prognosis. What do the prognosis depend on? The prognosis depend on the primary injury, primary impact, and which nobody can do anything about. Okay, and the only thing we can do medically is to prevent the second injury. You know what the second injury are about, I presume. Okay, I'm not going to explain.
I do.
Okay,
yeah, but
so that's the thing that we can do, and we have to jump on them as soon as possible, and with all of the full stop, what they call neuro intensive care. And you happen
does it matter? Yeah, does it matter what the 25-year-old person who has a devastating brain injury would have wanted?
Yeah, I think it matters, and I think, Dwayan, with all due respect, I think that's a little bit distracting from the core of what you were saying earlier. Because again, Anish, you bring up the fact that it's a matter of judgment. What I think, what I'm trying, and Dwayan also is trying to point out, is that the question of whether something is alive or dead is not a matter of judgment. I mean, if we start telling medical students it's a matter of judgment, then there's no end to the insanity.
I understand. I completely understand what you and Dr. are saying, and I think it's a fantastic point. And I think we need to be more transparent about it with family, and I think the point is also valid that sometimes this may be used by the physician community to give patients and give family members a sense of finality that then allows them to make a decision for, say, organ transplantation easier. So I do understand your point, but the struggle here is that there are obviously my feeling is that the large group of both our medical colleagues, as well as our citizens, our patients, and their family members, even with kind of this more transparent approach, are still going to be left grappling with the same basic issues, which is that you've had somebody that's had a catastrophic injury befall them, and regardless of the definition specifically of whether this is a corpse that's being kept alive, or whether or not this is technically alive or not, or there is what we've all seen, which is massive significant irrecoverable brain injury.
Yeah, but
and,
I mean,
for many
right.
people, that is the whether they can verbalize it in a specific way that would satisfy both of you or not. For me, or for many others, it would be the equivalent of dying, if you will. Now, dying is, but of course, you're trying to put life and death in some straitjackets in terms of what that means. Meaning, for me, I'm just telling you, for me, if I suffer a significant stroke that prevents me from getting out of leaving a bed,
right.
For me, that is dying in a way. Now, I'm saying dying in a way because I don't want you guys to jump on me to say, well, you're technically alive. Yes, I'm technically
I
alive.
mean, fine. Let's
say,
say, right, but
why not?
Why not
Yeah.
tell the family? I mean, why not tell the family?
Okay.
And
Exactly.
and so let's say, but because from the perspective of the family, they're going to be separated forever from that patient with an irreversible coma, either because the tube gets pulled out and then the patient dies, or they go to the OR and then they get their organs harvested and then they die. So from their standpoint, there's no difference.
No, I agree.
The only
So
difference
fine.
is perhaps, I mean, in a way that it could weigh into the decision would be whether they view the organ donation as some kind of gift to society that they would like to make on the behalf. I mean, perhaps. I mean, but that would have to be clarified. So,
but I think it would be wrong. I do think it would be wrong to come away from this saying as to leave families with the or to leave people with the impression that harvesting the organs was the mechanism for death.
Oh no! I think that's of course that's correct.
That is actually
of course that's correct, Anish, because I mean that has to be
okay. Then we'll call it death 1.0 and death 2.0. So fine. So you
no, but
right,
but
right. What happened is that at the end of the day, okay, given the fact that we live in a pluralistic society, I think every family and every person who signed this card for the donor must know the truth. All right, that you see what happened is the other thing is we think right now, my goodness gracious, that if this event happened to me, then please do not keep me alive. But you will be surprised. Okay, especially people who suffer stroke and then got partially recovered. Okay, that they are very happy to be alive, even though quite disabled. And I can say this based on how you say firsthand. How you call that?
Well, that's pretty selective, right?
But that's
many people that
vary from one person to the next. Okay.
Yeah, no, right. So I mean, isn't that my decision to make right now when I have full faculties?
Right.
I mean,
but let's separate again. Let's separate the decision with the description of what the reality is.
Sure.
So
I think you're on very strong. Footing there. I have nothing to argue with you about there at all. You're right. You're absolutely right.
So if that's the case, then it's correct. Then it's correct. It's correct that the organ harvesting will bring about the death of the patient.
That will bring about a certain finality. Yes.
No. I mean, it will bring about. I mean, if on the one hand the choice would be keeping the patient on a ventilator for another 6 months versus taking them to the OR for the organ harvesting, I mean, it's clear that the organ harvesting is what is going to bring about the death of the patient.
Right.
Let me tell you.
And so. So I think that there. I mean, just at that level of being truthful, I think it would be important.
Yeah.
Without removing the choice for the families, perhaps to make a decision to donate the organs. But if it weren't going to be a huge detriment to the transplantation process, then it would have been done from the get-go. And the reason it's not being done to this day despite
Right.
I think the manifest philosophical problems of dancing around questions of essentially fundamental truth, it's because it's being perceived by the medical community as a huge threat to organ transplantation.
Well, you know,
And so
Michael
the
Knapp.
question is
Uh-huh.
is it a better world to uh, accept kind of a big lie, wink wink, because it really it's what it is, Anish. If you think about it, if you spend any time thinking about it, and if you look at the literature and what Dwayan was mentioning, the backdoor. In fact, much of it has been published actually in papers. The
Yeah.
backdoor deliberations of the Harvard Committee about brain death and whatnot. It is kind of a wink wink, thing about talking, saying that up and down is, is it worth to really completely upend an absolute essential truth about life and death that is not controversial? It's a matter of science, as far as I'm concerned, just for the short-term gain of having organ transplantation, being done, and I think that's a very dangerous proposition. But I'm more interested. I'm more interested in really just the scientific points, because we don't have much time now. It's been already an hour.
Yeah.
I was hoping to spend actually a little bit of the time talk about the justifications, the philosophical justifications that came up to say that why the brain as an organ
We're gonna have to
is
do that next time.
responsible for,
Yeah, we could
right.
do it. We do it next time.
Because then you would see, and I think there's a philosophical merit to say, why is the criteria of cessation of pulse a better criteria? I mean, really a plausible criteria. Again, you never know when the pulse stops. You don't know that the patient is dead immediately, and you don't know that for a fact.
Right.
But it's a better criterion philosophically than the criterion of the brain being what they ended up calling the integrator of the body.
Right.
But I think you have to do this next time. I just want to give you a story. This is a real story of a mother of a brain death young man from accident. From Germany, and she she agreed to the organ donation. And in Germany, obviously, the criteria for brain death is whole brain death, okay, not the brainstem death like in Jamaica. Anyway, and also they had to do cerebral blood flow and EEG, right? Those things are not optional. So the mother obviously saw the son before the organ harvesting, and the mother saw the son after organ harvesting. And from that time on, she became against brain death. Why? Because the facial features of her son were those of expressing tremendous amount of pain. All right.
This is
yeah.
this borders on this
is not one case. There's, if you read the literature, when they did the sternotomy on a patient, the blood pressure goes up, and the cases, the blood pressure goes up, as well as the tachycardia.
Right.
All right, and that there's lacrimation. Just read the literature. And
right. I'm willing to believe it, Dwayan, but I think it's not central to the argument.
It's not central to the argument. But what I'm trying to say is, one case is enough to show you, okay, if somebody insists that brain death is that simpliciter, all you need is one case to prove that the theory is wrong. Okay.
That's it. Again, I think that's it's arguing against something that most pragmatic people aren't having an argument about. I mean, if I were to have so it's fine to say that, but again, if I were to have a massive injury to my brain right now, I don't want to, regardless of whether I lacrimate when they cut into my sternum to take my heart. I'm telling you right now that that's okay. please go ahead. If I've had a massive brain injury, because I see the other side. I see nursing homes and certainly hospitals with a fair share of folks with pretty advanced brain injury that have lives that I don't want to lead. Now, it may be that they want to lead that, but I can tell you that in conversation with many folks, most folks are probably not desirous of doing that. So,
yeah, you don't have to live. That's true. We just have to yank it out from you and let you die naturally, without having to cut you up and treat you as if you were a bag of organs. That's a different thing.
Yeah.
Okay.
I know. I think there's an well, I don't know that there's a lot of purely objective parties to all of this, and I think
I know, but
both of you, right?
Right,
So,
you're right. But let me put it differently, Anish. Just to tell you, tell you what my perspective is. Let us set aside all the the pragmatic ethics of it and whatnot.
Yeah.
But let's say, imagine you had discovered a huge conspiracy, not a huge conspiracy, but some kind of conspiracy to tell you that that the geocentric cosmology is correct, and the putting the the Earth at the center, having the sun rotate around the Earth.
No, that would be significant. That would be big.
Right, that'd be big, right?
But that's not the analogy that I would make. I understand why you're making that.
No, it is in a way, because say if we don't make the Earth be the center, of the universe, and have the sun rotate around the Earth, there's going to be a lot of social unrest. People are going to find that they're no longer anchored to, to being the center of the universe, and blah 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 and blah blah blah. But wouldn't you say at the end of the day we have to? I hate that phrase now. Listen to the science, right, and follow the science.
You have to be truthful, realist to the science data.
Number one, I find it interesting how Michelle is suddenly empirical. Number two, the analogy I would make is is that this is kind of like trying to figure out whether Pluto is a planet or a moon.
Right.
Meaning, again, I think that's the crux of that's the crux of this. That's why I think you're going to have it's like swimming upstream, because I'm telling you, people don't think of life and death in this very concrete way that you're defining it. And I wonder, it's interesting because you're both Catholic, so I wonder if. So I don't have
nothing to do. I'm a philosopher.
Nothing to do with it. Okay, but regardless, it makes me wonder. But because most of the people that I run into, and certainly the way I think about it, is that there's a meaningful death. There's death.
Yeah, I think you're projecting your educated white adjacent values here.
Yeah,
because the majority of the people at the bedside, families at the bedside, if you tell them he's still alive, they're going to react you have no idea how they're going to react.
He's still,
so it's not a what you think is a matter of.
What they want to know is, will I get Paul back? They're not necessarily interested in is the living, breathing thing is the living the heart that's beating. Right?
Then you have to explain, why are we going through these contortions? Why are we doing those? Why are we doing through those contortions if that's not going to be a meaningful change in behavior at the end of the day? So what's your explanation? Why 40 years after the Harvard criteria, we are still calling it, and people are still insisting, and neurologists, when Jahai McMath, that's the case that sort of got me on that path. Why did they insist on calling her a corpse?
Look, I think it's silly, and I think it's silly, and I think I see what's happening in the neurointensive care unit, where now you have this specialty of neurointensivists, and depending on there's a lot of stuff now on, well, we just don't know. Prognosis is something that we can never tell, and therefore, I've been involved in at least a few cases where you have some really significant bad outcomes because you do keep the breathing tube in, you do put a trach in. You do kind of say, well, we don't know, recovery. And then, I'm seeing the brother and the sister now 2 years out, and, they cry every time they're in the room and they talk about what's happening to, their loved one who's in wherever, bad location they are, because there's been, no meaningful recovery. And they tell me without a doubt that, what we did, 2 years ago in trying to do, we shouldn't have listened. We should have let him go. So there are, of course, multiple sides to
right,
this.
but again, it's different. I mean, even 2 years ago, you could have said, you know, there's no hope of meaningful recovery. You know, whatever you want to say, whatever you, there's no hope that you will have, or that the patient will have the life that they wish they had. There's no hope. You can say that right now to any of these patients. There's absolutely no reason not to say that. So my question is, why do we call them dead? Why do we call them, as Dwayan said?
Yeah, because we are afraid of decreasing our organ transplantation. But, you know, at this point, I want to tell you something. Michael Nair Collins, he has been calling for this transparency. And he pointed out that one of the main reasons why public policies have not been transparent is because of this fear that organ transplant would be, you know, the availability of organ would decrease. But he raised the issue, would that be, all right? Because there would be many people who, like Anish, who get into this kind of situation, and they would be willing to give organ. So Michael Nair Collins said that we do not know. It may not come down. You know, we may still have good amount of organ transplantation. We do not know, okay? But there is a definite fear of telling the truth, because there's a definite reluctance of telling the truth because of the fear that there may be decreased number of available organs. That's the crux of the problem, okay? And I think it was summarized very, very well by the paper, I think it was in 2019 or 2018 by Michael Nair Collins, okay?
Well, we'll put that on the show notes, and perhaps we should end on that note, which I think is very, very well said, Dwayan.
Excellent.
Thank you very much. I mean, I don't know if
so much.
you know, it sounded at the end that we're sort of going around in circles, but perhaps not. And perhaps sometime we'll actually go into the actual, which to me are interesting, the science, because they're interesting because they're so absurd, Anish. You would have to see what the philosophical contortions that they've gone through, the scientists, to once brain death was fully accepted, to actually come up with philosophical justifications for it. And so,
to be continued.
To be continued.
Yeah, to be continued. To be continued. Alrighty. Thanks so much.
All right. Thank you very much.
All right. Thank you.
Bye.
Bye-bye.